Secretion management, the bane of all ALS patients, otherwise known as sialuria. It occurs secondary to weakened oral and oropharyngeal muscles. It's not because they're making more secretion. They just can't swallow, resulting in the patient being unable to swallow enough saliva to prevent pooling and overflow. Effectively treated with low-dose anticholinergic antidepressants such as Eliquis, that's usually what we start with, 10 milligrams. Anticholinergic medications such as transdermal Scopex, some patients can't tolerate, they're allergic to the adhesive. Use of atropine drops or Robenol, oral suction. Every patient with ALS who has any kind of secretion should have a suction machine in their home, next to their bed. Botox injections into the parotid and into the submandibular glands are very effective on some patients. Can lead to, so what does this pooling lead to? It can lead to halitosis, very uncomfortable for the loved ones around the patient and for the patient because of the buildup of bacteria. The pooling of saliva may lead to silent agitation. Need for good oral hygiene. Okay, so the slippery slope with managing sialuria for all of the hospice nurses and our neurology nurses like myself. Finding balance between drugs. Mucus can accumulate in the back of the throat when the patient has swallowing problems and or an ineffective cough. These patients cannot cough, get it up. Patients often fear choking on their own secretions because they've read all these horror stories on the internet that they're going to choke on and die from choking. Medications are used to thin secretions, guaifenesin, Mucinex, and prevent postnasal drip. Nose sprays such as Nasacort and Flonase. Antihistamines such as Claritin and Allegra, and I use Zyrtec. Love Zyrtec. Okay, airway clearance treatments such as nebulizers, cough assist helps to thin and remove the mucus in the upper airway, allowing for greater breathing comfort. Maintaining good hydration and humidity are essential, especially now that the heat is on and everybody's home, the air is so dry. So we talked about pseudobulbar affect, so before or involuntary emotional expression, i.e., inappropriate laughter or crying. We talked about difficulty stopping. Some patients are very embarrassed by it, and others don't seem to mind at all, especially when they're giggling. I have a patient that I see, and we've offered him medication. No, he said, I don't mind giggling. Well, everybody around him does. But he doesn't mind it, and he's still in the confidence. He's decisional. So, Nudexa is the drug, FDA approved, the first drug to come out for pseudobulbar affect. Amitriptyline does work, but it is also can be very complicating if you go into the higher doses. Depression, a common response for any person who faces dying of a fatal illness. You're getting this diagnosed, why wouldn't you be depressed? Right? So you will see most of our patients come to you, they're on an SSRI, they're on an antidepressant. They're greatly beneficial. Supportive therapies and interventions provided by social workers, mental health care providers, and spiritual counselors are very helpful. Kindness and understanding from the entire care team, engaging the patient in conversation and activities when appropriate, not to be ignored, to be talked about. Insomnia. Try to determine what the possible causes are. May be related to aches and pains, breathing discomfort, room temperature, anxiety, depression, or fear of any combination. The most that they're afraid of, these patients, are to wake their loved one up constantly during the night because they can't turn. They're immobilized. They just can't move. They don't want to wake their loved one up, so they lie there and they're with their eyes awake and they don't sleep. So treat the underlying symptoms accordingly. Offer relaxation techniques, a bedside fan, elevating the head of the bed, putting the call light within the patient's reach, very important. A pressure relief mattress, a back rub, sleeping aid, or anxiolytic, a few words of and with sympathy. Constipation, common problem with many causes: decreased activity, change in the diet, reduced vital capacity, narcotics, and drying age. So again, hydration might be the answer. Just adding more liquid. If they can't swallow and they have a peg, increase the hydration in the feeding tube. Add it to the bag of the feeding. PRN medications or daily or every other day bowel program may be needed. Consult a dietitian for patients on oral feeds, and to review the form. It could be something as simple as changing the formula through the peg feed, something with more fiber, something as simple as that. We all have the ability at the end of an ALS patient's life to help them live with dignity, to help them live without pain, to help reduce their fears, to offer a safe and caring environment so they may die in peace. And thank you for your time, caring, and hard work, and help us join in our fight to help strike out ALS. This is our 40th year of the Les Turner Foundation. So we've been doing this for a long time. I've been doing it for 22 years. And this is the way to help. So much more needs to be done. And thank you.
Thank you.
Okay, yes.
You said that you were using Elavil for the secretions,
Yeah.
and then you said about depression with the SSRIs. Do you add that on, or do you increase the Elavil?
Add it on.
Add it on.
You have to go to a very high dose with the Elavil to really work it. And then it becomes a constipated. I don't know how to get mine on. Oh. There it is.
All right. So yeah, hi, I'm Sherry, respiratory therapist with Health Technology Resources. And so I'm going to touch on the respiratory therapies that we do with our patients in the home, and then even for your inpatient staff here. If they come here for respite or whatnot, they're going to be on these therapies here as well. Yeah. Excellent. Okay. So as Ileane said, one of the major things with our patients with ALS is shortness of breath. And of course, the reason for that shortness of breath is that low muscle tone of the diet. Okay. They're not able to keep up with that breathing, and like she said, which can definitely cause an increase in carbon dioxide levels. And if you have your patient complaining of shortness of breath, and or if you have your patient if you notice your patient has low stats, okay, low oxygen levels, don't think what you always are used to thinking, low stats means you need effective oxygen, okay? Shortness of breath and low saturation on a patient with ALS is because of the CO2 levels increasing. Okay. Let's say you walk in, your patient has a stat of 86%, and they're not on their BiPAP or their VPAP, which I'll get to in a minute. Put them on their mask. Okay. Their saturations are low because their breathing is so shallow. All right. So if you get them on their mask, we're going to get a little bit of a bigger breath in, get a little bigger tidal volume in, which is going to automatically increase the saturation. Okay. Like Ileane said, the only time we're going to give supplemental oxygen is if something is actually going on with the lungs, if they have pneumonia, if they have a PE going on. And then the only safe way to deliver that supplemental oxygen is in line with their mask, to blow off that CO2 while we oxygenate the patient. Okay. I'm going to flip through these quickly because I want to give time for questions and answers as well. But all of you guys can get a copy of this PowerPoint to go more into detail. And my card's at the back, so you can always call me with any questions, okay? So NIV. NIV stands for non-invasive ventilation, okay? Especially today's day and age, I would say there's no reason to send a patient home with a tracheostomy tube because there are a few in between there. But really, we want to do non-invasive. We want to ventilate our patients with a mask, okay? You could do nasal pillows, nasal mask, full face mask. All three of them work, okay? You could do mouthpiece ventilation. One of the newer things with the Trilogy or the Astral is the sip and puff. So basically, if you have someone who does fairly okay during the day, but they really just need their mask at night, they can do sip and puff ventilation during the day. So basically, they have the machine. When they want to take a couple of good breaths, they just take a little puff off of their mouthpiece here. Just pull that up. You just have your tubing attached to your breathing device with the mouthpiece. And when they want a breath, they're just going to initiate a breath in. The machine's going to kick in, give them a little bit more volume, and they exhale. They can do that a few times and put it in back. patients who, you know, kind of need that extra boost, but they don't want to be seen with a mask around family, around friends, in public, I would say let's do sip and puff during the day then, if that's sufficient for them.